Okay, good morning, everyone. Thank you so much for joining us. We're thrilled so many of you have come out bright and early on this Tuesday morning. Just as an aside, we're joined by people from 4 different countries in 6 different provinces, so we're thrilled to have you all with us. My name is Kyle Fitzgerald. I'm the Manager of Government Relations with the Alzheimer Society of Ontario. Just a few housekeeping items before we get started in earnest. This webinar is being recorded, including any comments typed in the chat box. The recording will be shared publicly, and the link will be sent to everyone who registers after this webinar has concluded. Because we do have so many people on the webinar this morning, everyone has been placed on mute. After Dr. Alessi has finished his presentation, we will have a short Q&A session. If you have a question at any point during the webinar, please type it in the chat box. We'll make a note of all the questions that are asked, and during the Q&A session, we will try our best to get as many of your questions addressed as possible. And with that, I'm going to turn it over to Kathy Barrick, Chief Executive Officer with the Alzheimer Society of Ontario, to introduce our presenter this morning, Dr. Charles Alessi.
Good morning, everyone. Thank you, Kyle. The Alzheimer Society is delighted to be hosting this webinar. As a frontline provider of community support services, we serve 86,000 Ontarians living with dementia and their caregivers every year, providing respite, counseling, education, system navigation, and other supports. Our staff see firsthand the challenges families face when interacting with our healthcare system. To help us understand the global lessons Ontario can learn around dementia care, we are joined by Dr. Charles Alessi, Chief Clinical Officer with the Healthcare Information and Management Systems Society and Senior Advisor to Public Health England. Dr. Alessi is a globally recognized and trusted leader in healthcare. He brings a wealth of experience, particularly around health systems and the interface between healthcare, social care, and the personalization of wellness. He is a physician in London with more than 35 years of experience in all aspects of clinical practice in the UK National Health Service. Most recently, he served as chairman of the National Association of Primary Care, where he was at the heart of health and social care reforms. He forms part of the World Health Organization expert panel that is formulating new guidelines around risk reduction in dementia globally, and also leads thought leadership around productive, healthy aging. Dr. Alessi holds a variety of international academic positions, both in Europe and the Americas, and is published widely in the media and journals. He is an adjunct research professor in clinical neurosciences at the Schulich School of Medicine at the University of Western Ontario, and a visiting scholar at the Odette School of Business in Windsor, Ontario. He continues to advise major corporations and national governments around healthcare reform, particularly where systemic reform and digital interventions are being considered. Dr. Alessi, the digital floor is yours.
Thank you, and thank you very much for the opportunity to have to speak to you all about where we are in our journey around dementia and assisting people and their carers who are living with dementia. Because I think it's about time we had these sorts of conversations, as there have been so many changes and so much written recently and published around dementia, and also about treatments and risk reduction. So I think it's a really opportune time. So I'm delighted to accept the invitation, and I'm honored and thank you for the invitation to speak to constituents in Canada. So first I'll start with a conflicts of interest statement, and could I have the next slide, please? I think it's important we always make sure that we're clear in terms of who we are and what we bring. So this is done in complete independence from the event organizer, and this is my role with Public Health England. I'm the Senior Advisor and Lead for Dementia, and I'm also Chief Clinical Officer of HIMSS, which is a global not-for-profit organization. Next slide, please. What I'll talk about today really is the English journey, the journey we went through over the last 5 to 8 years, really looking at how we managed dementia, how we assisted people with dementia, and what we could do better around not only the treatment, but the support of people and their carers. And I'll go through some chronology around that. So starting with where we started in terms of risk reduction to changes, you know, possibly also associated by politics as well as evidence, and then looking at a global view at the end. Next slide, please. And there are some lessons, I think, which are immediately clear, and they're clear before we even start. As always, whatever the outcomes and quality of evidence, sadly, there never is a guarantee that anything will ensue. We know this over years and years of experience. Stories and research started around the effect of statins on blood lipids many years in advance of the days in which people started to systematically treat people who had high blood lipids with cholesterol agents. Similarly, it was many years between the time that Richard Dawell wrote a very famous paper about the effects of smoking on English general practitioners to the time when we actually took action around the effects of tobacco on the incidence of lung cancer and cardiovascular disease and everything else that happened since then. So, you know, we have to be clear that whatever vehicle we think will deliver change, often that is not the case at all. And in many respects, I think what we've learned is by speaking about it, and also by being honest about it and being transparent about change or the inability of us and organizations around us to change, perhaps there'll be a much greater chance of positive things happening. And this is my sincere aspiration. And I think we're learning that this is indeed the case. Next slide, please. I don't really think I need to go into what the risk factors for cognitive decline and dementia are. We all know what they are. I mean, aging is the fundamental and most important single risk factor. But of course, cognitive decline is not an inevitable part of aging, but aging is a risk factor. But there are other conditions which predispose to cognitive decline and to dementia, and they range from high blood pressure, lack of physical exercise. We know there's an association between diabetes and cognitive decline. That's often expressed really as the association between diabetes and stroke and heart disease. We know these things are interlinked. We know that smoking, excessive drinking, poor diet, chronic kidney disease are also important. And we also know that low educational attainment is a risk factor, and higher cognitive abilities and higher educational attainment seems to be a protector. Next slide, please. And really in England, we got to a place where we realized that perhaps a third of cases of Alzheimer's disease may be attributable to these risk factors. And thus, you know, reducing those risk factors by 20% in a decade could reduce the prevalence by significant numbers. And we then moved to a strapline, which we're using all the time, which is what's good for the heart is good for the brain. We talk about that quite a bit because people accept now that there are things they can do today to avoid getting conditions which they would rather not get tomorrow. So people understand that physical exercise, stopping smoking, are really quite important in terms of managing their cardiovascular health. And what we're trying to describe to people is the fact that this is also true for conditions like dementia. And of course, this is a nuanced message we're giving, because the worst thing that we could be saying to people is if you got dementia, it's all your fault because you didn't manage your risks better. That is not the case. What we are saying, however, is that if you manage your risks as well as you could, you reduce the chances of you developing dementia. That doesn't mean you abolish the risk, it means you reduce the risk, and there is a difference there. So let's move to the next slide. And I think I'm going to spend a little bit of time on this slide because it really describes the journey that we went on in England between May 2014 to 2019, a 5-year period, which changed the nature of the conversations around risk reduction in dementia. Dementia was then, as it is still now, a condition which affects significant numbers of people, but perhaps in 2014 there was less of a realization that there were things one could do to decrease the risks of developing dementia. Then perhaps, and I remember these conversations very well with colleagues who were cardiologists, geriatricians and neurologists, the perception really was that, well, you know, you got old and you got dementia. The two were intertwined, and there was an inevitability about one if one had the other, i.e. there was an inevitability of developing dementia as you aged. And it became clearer looking at the evidence that that was not the case. But it proved to be really quite difficult to kick this off. So we started the conversation around May 2014 by actually pulling in some global experts, some from Canada as well, I might add, looking at dementia and the fact that there was no reason why we shouldn't start thinking of dementia in the same way we think about cardiometabolic disorders. In other words, in the same way we think of diabetes, whereby there are things we can do to try to avoid and try to delay diabetes. Cardiovascular disease, exactly the same story, and dementia, exactly the same story, even though the evidence then was certainly not as clear as it is for the other two conditions. And the exact wording is that the evidence was sufficient to justify considered action and further research on risk reduction. Things happened quite quickly after that, with Public Health England then identifying dementia risk reduction as one of its 7 priority areas, really trying to set up a process which would lead to us having a systemic approach to risk reduction in England. And I started chairing the Dementia Programme Board, which was set up then in October 2014. And very soon after, as you can see, in a matter of months, we started working far, far more closely with the voluntary organisations, with the Alzheimer Society, with Alzheimer's Research UK, two really quite important organisations, specifically looking to how we can actually ensure we had congruity in terms of the messaging we're giving, and also to see how we could put our shoulders together to ensure that we were concentrating on the things we needed to, and tended to do this a little bit better coordinated, because it made an enormous difference. We started to develop a work program around healthy people, started to develop strategies around stakeholders, and we also set up PHC networks, and I'll come back to that and explain what that is a little bit later. The networks were really small areas of England where Public Health England was collating data around dementia and around the risks associated with developing dementia. Not long after that, in March 2015, the World Health Organization, there was a call to action around the global action against dementia, and we were particularly involved with that, as well as Canada. Again, we seem to be traveling in very, very, very close lanes with our Canadian colleagues in all of this, because we're often present at the same meetings, and we seem to be talking the same language more and more. And by April of 2015, we even got agreement between the different nations in England, in the United Kingdom. I don't know whether you're aware, the United Kingdom is not a federal state, of course, unlike Canada, but we do have 4 separate health systems. England, Scotland, Northern Ireland and Wales have 4 different health systems, hence, we needed to make sure we had alignment in terms of the programs. And those are called the devolved nations, where we got agreement that we would all work together around risk reduction in dementia. By October 2015, the National Institute of Clinical Excellence started to publish evidence around midlife approaches to delay or prevent the onset of dementia. This was of seminal importance because really, until then, there still was perhaps a disinclination to take risk reduction seriously. But with the publication of NICE guidance, it became really more mainstream that people were talking about risk reduction as being something we all needed to consider. And similarly, a few months later, when the Prime Minister of the time, David Cameron, decided he had a particular interest in dementia, and he published his Dementia Challenge, which really meant implementation of forces in the country to really manage dementia better. We were in a place where, from being in the periphery, we were right in the mainstream of change which was taking place. A couple of years later, we also managed to include dementia risk reduction in the NHS health check. The NHS health check is provided to each citizen in England who hasn't been in contact with the health and care systems, and it's a free cardiovascular check in essence. And we start performing health checks on individuals from the age of 40. Now, in the past, dementia wasn't part of the conversation at the age of 40, but, and it was only in people who were 60 and over. The health check program runs from the age of 40 to the age of 70. So what we managed to achieve was that at the start of the health check program, in other words, for every new 40-year-old that went into the program, risk factors of dementia were discussed with the individual to ensure that people were aware that there was something they could do today to hopefully stop them getting dementia tomorrow. That really was the whole basis of that exercise. And culminating in May of last year, when the World Health Organization published the Dementia Risk Reduction Guidelines. And now this is something which is taking place all over the world. And by this, I mean the systemic approach to managing the risk factors around dementia. Of course, it changes depending on which country you're dealing with. Could I have the next slide, please? Thank you. Just some smattering of some publications. I'm sure you have the same in Canada. Publications for the population, some from some of the voluntary organizations, some others from Public Health England, and including some movies, some film clips. And again, if you look to the bottom on the right of this slide, you see a picture of a lady. That lady is Angela Rippon, who was quite a famous presenter on television, and we used her as the voice of dementia. We started to understand far more that we needed to get people to understand that this affected them. This wasn't purely an academic exercise. Next slide, please. And this really is one of the things we published, which I think is probably one of the most important things we published. We realized that if we really were trying to change the level of risk that people had, we also needed to set a system up to measure that change, not only amongst individuals, but probably as importantly among the health workers and health systems that actually manage those individuals. And to this end, we set up the Dementia Intelligence Network. This is available on the Public Health England website. I'll come back and give you the address of that in a subsequent slide. But in essence, what it does is it looks at different parts of England and it measures a whole series of indicators which really start to give a sense as to how well people are being cared for. And what it measures is prevalence, in other words, the number of people that actually have been diagnosed with the condition, as against the number of people who we would expect to have the condition, given the fact that we know the approximate percentages of people who develop dementia and their age profile. The second metric we measure is prevention, preventing well. In other words, we selected some metrics that actually indicate prevention, things like levels of smoking, things like levels of blood pressure, etc. The third metric is diagnosing well. In other words, how well are you diagnosing the condition within that system? The fourth is living well, and how supportive are we of people who are living with dementia in their life course. The fifth is supporting well, which means, and that's directed more at carers, how well do we support people and the carers around them? And the final one is dying well. How well do we support people at the end of their lives? Next slide, please. And what we tend to do is look at all these metrics in different parts of the country. And at the top, you there see the website, which is freely available. You can go and have a look at it if you like, fingertipsphe.org.uk. You look at a different area of, sadly it's only England and not Canada. Perhaps you'll have the same in Canada. I think these approaches are particularly powerful, certainly amongst the caring professions, because they enable an area to compare itself to the next area in terms of outcomes. And you can compare yourself to another area, you compare progress where you are now as to where you were in the past and where you hope to be in the future. And as I said, this is all wholly available. Now, of course, none of this information is identifiable on a personal basis. In other words, people's confidentiality is, of course, protected through this process. Could we go to the next slide, please? And then politically things change, like they usually do. We had a general election, we had a resignation of a prime minister, and suddenly dementia and the dementia plan was perhaps not quite as important as it had been in the past. And this is inevitable. When governments change, emphasis and directions and initiatives change, and every prime minister wants their own initiative. And the initiative which David Cameron had around dementia was very unlikely to be the same initiative which the next Prime Minister, who was Theresa May, would have. So hence we changed the context a little bit around dementia and started talking more about aging and dementia. The two, as we know, are related, but I think it's important we started thinking in terms of productive, healthy aging, because the only way we would manage productive, healthy aging, in other words, to ensure that people lived as productive a life as possible, as well as long a life as possible. And as you know, we have managed over the years to get increases in longevity, but what we haven't managed to do is to get increases in healthy longevity. And really that was the challenge here. And it included within it changing the context around how people think around aging. Next slide, please. And we started talking and thinking about aging in a different way, from the classical way we used to think about aging. And if you look at the top of the slide, you'll see the current model of the three-stage life: birth, leading to education, either primary, secondary school, and university, or primary, secondary school, technical college, or primary, secondary school only, followed by your work time between the ages of 16 and 64, followed by retirement. And that is historically what's happened and what has happened really in most of the Western world, to thinking around the multi-stage life, which is described on the bottom of this slide. So from birth to education to work, again, re-education halfway through your working life, another period of work, re-education again, working for longer, of course, leading to retirement at a far later age. Next slide, please. And we contextualized risk reduction into productive, healthy aging and brought within it context around the importance of financial security, the importance of meaning and purpose, high quality work, caring, volunteering, connectiveness, still maintaining the importance of physical health, maintaining the importance of exercise, maintaining the importance of managing blood pressure and smoking, as well as talking far more about resilience. Next slide, please. And we're now moving to the new world within public health, where we're starting to think in terms of how we manage risk reduction and how we manage assisting people in the 21st century, in the 2020s, where perhaps people are more, will be more attuned to a system which will introduce change to them on a personal basis rather than a population basis, is more customized, and utilizing digital technologies to achieve this. In other words, directly connecting with people from Public Health England, making it clear to them what they can do, potentially also assisting them making those changes, i.e. referring them to relevant agencies where required for those changes to take place, and also ensuring that if we can, we use personal data properly safeguarded, of course, to really change their expectations of health and care and to assist them to live healthier and more productive lives. Can I have the next slide, please? Because really, in terms of where we're going, our view around precision health is we wish to prevent or delay ill health. We're back to productive, healthy aging, and increase the expression of disability-free years. And this will also, of course, reduce inequalities. And this is the direction of travel we're going through at the moment in England. Next slide. And you can see, if you look at where we are in terms of the future, we're really trying to leverage data to target people in a more personalized way and to give them the insights they require. All this, of course, with their full permission and support. Now, there was one other thing I wanted to talk about today, which is really what's happening globally. Because I think it's important we also look to what's happening in the rest of the world and in the world of dementia and of aging, because there are some very, very exciting things happening. Could I have the next slide, please? And I chose 3 countries to talk about, just to mention, just to make sure you're aware of them and you can actually look into them and look into their systems. And of course, in the age of democratization of information, it's very easy to find information around these systems. All you do is you Google some of these terms and you'll find all you need to know about them. So let me start with Finland. Finland's a particularly interesting country. It's a small country. It's only got a population of around 5 million. It's relatively isolated. It's up in the north of Europe, not that dissimilar in some respects to Canada in terms of its climate. And its percentage spend on healthcare is about the same as England's, as United Kingdom's. I think it's about 9.5% is spent on healthcare. So in many respects, it's a very similar system, except it has some significant advantages. One of which is MyCanta. MyCanta is their digital system whereby everybody's medical record is looked after by the state, is available to the individual, and that's why it's called MyCanta, and all their health records are available to every individual, and on that, they also are able, people are also able to add their health and wellness data to really encourage them to manage their risk factors better. This information is then made available to clinicians as a citizen requires, depending on the care they're getting. And my canter has been a remarkable success at actually activating people. And by activating, I mean getting people to take more responsibility for their health and care. Finland is a stupendous place to look at if one wants to learn the art of the possible in terms of getting people engaged into caring for themselves. What's also notable about Finland, perhaps, is its use of secondary care legislation. Secondary care legislation is the legislation which governs the use of data for uses other than for what it was originally collected for. There were various scandals over the years. We're all aware of them. These are global phenomena around the misuse of data, and governments are now introducing legislation to govern exactly how that data is used. And the Finns have really come before a lot of us in developing some secondary use legislation around that data. And of course, there is enormous value to the data, not only to the individual, but also for research purposes and for the country, because by collating the data and combining the data, one has many more data points to enable everything from the deployment of artificial intelligence to also simple research around causes, effects, etc., if one looks at trials and studies. And the process of inclusion that Finland has used is probably one of the best I have seen anywhere in the world. And it's really quite remarkable what they've managed to achieve. The second country I thought it would be worth considering is Japan. Japan is rather interesting. Japan is interesting for a couple of reasons. One, because of course it is the super aging society. And it is a society where people are growing oldest, quickest. And for that reason, it's certainly worth talking and looking to Japan, because I think we have a lot to learn around Japan and from what they did. And there is a very interesting initiative that the Japanese have been involved with. And that initiative is around the use of mechanized methods of actually managing cognitive function. And they particularly use this in a province called Kanagawa province in Tokyo, where they use a system called mimesis that actually measures levels of cognitive decline from simple recordings. And this is a remarkably good opportunity, I think, that the Japanese have taken to really industrialize the process of health and wellness. Am I still connected?
Yes, you're fine.
I am good, thank you. The third system I wish to talk about is excuse me, that's better. The third system I want to talk about is the Israeli system, because there are some notable, wonderful systems which were developed in Israel, particularly the health system of 40% of the population, which is a system called Clalit, whereby they have developed a system called Ideal Health, where they actively assist people and they include gamification in that process. In other words, they use incentives to drive changes in behavior and do it, again, on an industrial basis. In other words, covering everybody within a municipality. Again, these are wonderful, wonderful potential experiences, wonderful initiatives, and we're already seeing some evidence that in these countries, they're managing to decrease the number of people who are subject to cognitive decline more than they would expect. Perhaps this is happening quicker in Finland and Israel than it is in Japan, because Japan has some more fundamental problems. But in essence, what I wanted to describe was the fact that what is happening in a whole host of places. It's not only happening in England or in Europe or in Canada, it's happening globally. Of course, it's happening faster in places that have a greater need for things to happen quickly. But in essence, this is a worldwide initiative that's going on here. And I think it's about time we all were part of it. Thank you.
Thank you so much, Dr. Alessi, for that presentation this morning. We have about 20 minutes for a Q&A session. So just while people pull up the chat box and type in their questions to get us started, I'll kick us off with one question. On your timeline slide, speaking about the Prime Minister's challenge on dementia, you mentioned getting the 4 nations of the UK sort of on board with a similar strategy. And I'm wondering if you can expand on that, especially in relation to how it might inform Canada's national dementia strategy with our 13 provinces and the territories, and also in getting the different sectors of Ontario's healthcare system to all push in the same direction.
Well, in many respects, it was easier. There were 4, which is a significantly lower number. And in other requests, it's as difficult because getting primary care, in other words, community services and hospital services to talk together is as difficult in this jurisdiction in England as it is in any jurisdiction in the world. My sense is that I think the most important thing about Canada is that the health systems are sufficiently different for it to be relevant for, say, Ontario to have a good system, or Vancouver to have, or British Columbia, sorry, to have a good system, or Quebec to have a good system. In other words, the unit of currency may well be better in individual states in Canada. Of course, it's important to have a federal approach, but given that healthcare is devolved to the level it is in Canada, it obviously makes sense for that to be reflected in the policy implementation. Hence, I think the emphasis should be to make sure that voluntary agencies, as well as primary care, as well as the hospital sector, start to develop a unified strategy as each individual state in Canada. I think only then can one start to think in terms of doing this on a national basis. Because if you ask me where I would start, that certainly is where I would start, because I think there's more chance of something happening and it affecting people quicker if we go that way.
Okay, thank you for that answer. We've got our first question in the chat box here, and again, if you do want to type in any questions, just click on that little chat bubble icon at the bottom of your screen and type your question in there. This comes from Tazeen, who asked if you can speak to the reduction in prevalence that has resulted from any of the actions the UK has taken.
This is a really interesting question because, of course, one would have expected us to have had no effect by now, given that we really only started on this journey 6 years ago. So it's not that long since we started doing this systematically. But then perhaps everything has changed, and everything really has changed because what's happened is something called the finger trial. I haven't mentioned the finger trial, but the finger trial is actually quite famous. The finger trial was conducted in Finland by a lady by the name of Mia Kivipelto, who's Finnish but works at the Karolinska Institute in Sweden. And what she did is applied all the risk factors to whole populations in Finland, subpopulations in Finland, with very intensive interventions in the cardiovascular space. And even after a short period, and it really was only a couple of years, it was clear there was a statistically significant difference between the populations who were subject to the very intensive cardiovascular inputs as against the people who were not subject to the cardiovascular inputs. So this in itself is really very suggestive of the fact that something we're doing is working. The same could be true in England, where we have found that we certainly have seen a reduction in prevalence. Exactly how much of a reduction is not quite clear still, but we think we are looking to a reduction of between 10 and 20%, or we're moving in that sort of direction in terms of the expected number of people who are developing dementia, between the actual number of people as against the expected number of people. Now, of course, there is nothing, there is no proof that that is related to any of the interventions we've systematically introduced. In other words, systematic management of blood pressure, smoking cessation, and everything else we're talking about before. But surely it's encouraging that that is happening. So we have seen some effect, yes. And I think the same is true in other countries. The only exception where evidence is not as good as it could be is Japan. And it's really interesting trying to find out why Japan is an outlier. And there are very many complex reasons why that could well be the case, and also why perhaps that is changing at the moment. But that's outside. We can talk about that some other time, perhaps.
I look forward to it. The next question brings us back to your slides on risk reduction and the importance of early diagnosis. Could you speak to any successful awareness campaigns used in the UK to essentially make the public aware of these preventative measures, and if that moved the needle at all in terms of improving diagnosis rates, whether that's improving the number of people who were diagnosed or moving the age at which people were diagnosed further down?
There are a couple of questions in that. Let me unpack it a little. One, in terms of public's awareness. I think it became very clear that the people listened to people they knew and loved, perhaps more than they listened to authoritative figures. And I think this is a facet of 21st century life we're all getting used to. In other words, us using a television celebrity to talk about awareness and risk reduction was far more listened to than us using a scientist to talk about risk reduction in general, because people tended to identify more with the celebrity than they did with the scientist. That doesn't mean that one is worse than another, but perhaps the messaging that one uses and the attractiveness of that message changes depending on who delivers it. In terms of the physicians, in terms of the diagnosis rate, in other words, we wanted to improve the level of diagnosis to about 2/3 of the number that were expected to have the condition. People always get diagnosed late, inevitably get diagnosed late, partly because they don't want to know, partly because people don't want to diagnose them, partly because people don't present in time. There's a whole multitude of reasons why that is indeed the case. But we introduced a process of getting early diagnosis, timely diagnosis, we called it, introduced, because we felt it was more appropriate if we did it that way, and also tied it to some remuneration of, in other words, pay of general medical practitioners. And that certainly had kick-jolted the process forward. And since then, the process has continued, despite the fact that people are not necessarily paid anymore for diagnosing early. So we use incentives very often to drive change in the beginning, but that doesn't mean we keep on using incentives.
Okay, our next question gets back a little bit to the prevalence question, and that's can you shed any light on some of the non-traditional metrics that we might want to be asking to really move the needle in the right direction? So going beyond the traditional metrics that we might track, and what other indicators might we want to be looking at?
I think that's a very insightful question, and thank you for asking it, because we were limited in our choice of metrics for each of the conditions in the fingertips model I described earlier by what we were already collecting. We know that the non-health determinants or the social determinants, they're the same thing, but depends how we describe them, are at least as important as the traditional the metrics that drive risk reduction and also drive health and care. Indeed, it's thought that the traditional biomedical metrics that drive well-being to individuals are responsible for between 10 and 20% of the total value that an individual considers are important. Having a home to live in, somebody to love and somebody to love you, who loves you, having a job, having enough money to live comfortably is also important, and is probably more important. And I think the more we start to embrace this whole area of non-health determinants, the richer our information is. It's very clear when we look to value-based systems, which is the way health and care systems are developing all over the world. People tend to start to collect this information far sooner and attach much more importance to it. You know, the level of education of somebody is a good determinant to their wealth. Even a simple zip code as to where somebody lives gives you an awful lot of information as to level of education, employment, and by that I also mean how well they will react to messages around health and wellness. We know there's a difference in the way you deliver a message depending on the individual you're talking to.
Well, thank you for that. So our next question, just asked you to dive a little bit deeper into the Dementia Intelligence Network, and if you could provide a bit more information on that initiative.
This is one of a series of initiatives we have around information. And if you go to the website, and all you need to do is Google Fingertips Public Health England, you'll come up with the Fingertips website. And the Fingertips website consists of a whole series of areas around all diseases, from mental health to dementia to cardiovascular health. And it really is an encyclopedia to allow physicians to be able to see how well they're doing, and also to allow them to compare their care and their population with other populations. So this is a national initiative which is, all it is really is collating all the information that we've been collecting for a long time over the years. Until now, it's never been collected in the same place. This is collecting it all in the same place and then reflecting it in a way which enables people to gain some insights around how well care is delivered in one area rather than another. And it's very powerful. It's also powerful because the press tends to be very interested in the places that are particularly good, and it celebrates them, and interested in the places that perhaps could do with more attention, and really writes a lot about them, which leads to an improvement in the care that they provide inevitably, because, you know, people don't like to provide bad care. If possible, they want to provide good care.
Okay, so that's the last question from the group chat, but just in case anyone does have any other questions, I'll give them a bit more time. And I wanted to follow up on your previous answer when you spoke of the sort of the social determinants of health and how it goes beyond the traditional health sector. And I'm wondering if you can speak from your experience in the UK about how you change mindsets within various government agencies within the healthcare sector to change that impression of healthcare as only being about the provision of healthcare itself.
Oh, another $1 million question. It's extremely difficult to get different parts of government, A, to speak to each other, B, to take responsibility for each other's agendas, and C, to work together. We all know these are significant problems, and I might add they're not only English problems. I've seen them all over the world. I'm privileged in HIMSS that I travel the world looking at health and care systems, and it's a recurring theme around bits of government not working as well together as they could do. So this is happening everywhere. I think the most important thing is developing a narrative that is coherent. In other words, that gets you listened to. That's the first thing. Secondly, ensuring you actually get this highlighted in the media. This is really important because this is about push and pull. You could push as much as you like as an individual or representing an organization, but if there is pull associated with noise from the media and also from any other organizations, it's clear you'll have a greater chance of success. And also, third and most important, it's to work collegiately with other organizations in this space. And if there is one thing which has made the fundamental difference in England, I would suggest it's the work with the voluntary agencies. The relationship between Public Health England and the voluntary agencies is beyond excellent. We really do work together. That doesn't mean that the voluntary organizations don't challenge Public Health England where appropriate, because of course they have a role to play and that's understood. But in areas where one is trying to change perceptions, in areas where one is clearly sharing an agenda, there is a singularity of mind around the approach. And also, because of the long-standing relationships, there's an element of trust. That's a big word, trust, which enables the impossible to be somewhat more possible. And I think that has been the single biggest factor that has accelerated change in England.
So another $1 million question here, and I'm going to read it verbatim just so we capture the full intent. With diet as a risk factor and the expense of eating a healthy diet, or rather the inexpense of eating an unhealthy diet, has there been any initiative in the United Kingdom to address the inequities around access to a healthy diet?
Well, where does one start? There have been loads of initiatives around this space. And of course, the most famous is the sugar tax. The sugar tax really was an attempt made to highlight the importance of eating healthily. And I think it's one of many initiatives which are at present being undertaken. Have they actually managed the process as well as they could have? My sense is no. Have we managed to make healthy eating at least as cheap and at least as convenient as unhealthy eating? The answer is no. But I think we're on the way to doing that. We are seeing local government that is taking on more responsibility around ensuring its licensing of fast food outlets is managed better, certainly close to schools and places like that. We are seeing more emphasis being made by the supermarket chains on healthy diets because we are making quite a lot of noise about this. And as a result, people are actually asking quite a lot of questions about this. And as a result, then, of course, there's a commercial aspect. Suddenly it's in the interest of a supermarket chain to be seen as being the purveyor of healthy food as against its competitor who may not be the purveyor of healthy food. So all these things, I think, are working in the same vein. I think, however, that the days of banning things are coming to an end. That is very 20th century to a degree. And of course, with things like smoking, it is easier to do that because under no circumstances can smoking be viewed as something which is in the interest of your health to do. There is no time where smoking is good for you. But with food, it's a far more difficult conversation to have because, of course, we need to eat. The question is how much and what we eat. So it's a much more difficult message to give around food because it's also so tied, as you quite rightly asked, to income and to availability of food. But I think the direction of the future is using these precision health approaches and perhaps using gamification, in other words, using incentives to ensure that people eat as healthily as they can and to try to make the playing field a little bit less skewed towards the unhealthy food. By no means have we come to the end of the road in terms of managing this process. I think we're merely in the foothills of trying to manage these processes, but at least we started.
Okay. Looking at the time, let's finish up with the quintessential question to end a webinar of this sort. and that would be if you could wave a magic wand and make one change to a healthcare system within a given jurisdiction, such as Ontario, to make it more responsive to the needs of individuals affected by dementia, what would you suggest that change be?
It's actually not $1 million question because it's so blindingly obvious. What we should be doing in health. This is, and it's health and care. At present, it was metricated with activity to drive health and care, and then are surprised when our health providers provide the activity we pay them to provide, because that's what we pay them to do. And I would suggest that if we start to use some of the metrics, and there are some within fingertips we can use as well, to drive prevention and make that one of the metrics that drives health and care, I think we then will get far more engagement and far more importance given to preventative measures within health and care. But it takes courage from the employer and from government, if government's the employer or the payer, for these things to happen. And politics and vested interests and all other things intervene. But that is what we need to do. If we manage to do that, I think the rest will follow.
Excellent. So some homework for us to all walk away with. So that brings us just about to 9 a.m. our time. So on behalf not only of the Alzheimer Society of Ontario, but of everyone on this webinar, thank you very sincerely, Dr. Alessi, for taking the time to share your insights with us. I think we're all deeply grateful for the work and the leadership you're showing, not only in England, but on the global scale. And the sector is certainly better off for having you as an advocate. So thank you very much for taking the time. The recording of this webinar will be made available and will be circulated to everyone who registered later this week. But with that, thank you all and enjoy the rest of your Tuesday.
Thank you.